In this part of our lecture about neurologic pathophysiologies, we'll focus on altered mental status, some of the causes and things that can lead to that. Then we'll also turn our attention to both neuromuscular as well as myelin sheath disorders. So it's important that we be able to identify potential pathophysiologic etiologies of altered mental status. We've talked about some before, but we'll go over some additional ones. We're going to take a look at the negative effect of sodium imbalances on the central nervous system. This happens a lot in healthcare and in our patient populations that we work with, so it's important to know that. We'll look at Alzheimer's dementia, Parkinson's disease, and several disorders of the neuromuscular junction, and finally, the myelin sheath itself. So as we think about pathologies that can lead to altered mental status, there are a lot of different kinds of pathologies that may manifest with altered mentation. First, I think it's important that we remember that there's a difference between arousal and awareness. So when we think about arousal, we're talking about what's happening in the reticular activating system. So we're thinking about attention, information processing, consciousness. This is different from awareness, which is all cognitive functions. So we know that we need arousal in order for awareness to occur. So those cognitive functions, we are doing our attention processing, our processing of information, and then also our executive functions within our brain. So it's important that there's a difference between arousal and awareness. And we know that norepinephrine, one of our neurohormones, is especially important for arousal. We've talked about some pathologies that can actually alter mental status. We talked about the potential effect of a tumor, with stroke, with bleeding into the brain. So those would cause structural changes. Trauma can change our mental status. Infection, we talked about some of those as well. And then we talked a little bit about toxic substances and how those can actually alter the mental status or alter our ability to pay our arousal versus awareness. As we look at toxic substances, we need to think about a lot of different things. We need to think about alcohol. This is especially important in the heavy use of alcohol. There was a very interesting, I just had to tell you about this study because, well, I just had to tell you about it. So basically what they looked at, and this was a study done by Woods et al., and they looked at a total of 69 subjects. And what they identified is they looked at heavy use of alcohol and looked at cognitive deficits. So when they looked at heavy use in people who were older had greater cognitive deficits than younger heavy drinkers. And these were all in heavy users. So when they looked at those cognitive deficits, the cognitive deficits were in learning, memory recall, and fine motor function. There was no difference in verbal processing or in processing speed. Now they defined heavy alcohol use as greater than 5 drinks a day in a male or greater than 4 drinks in a female. And this is by day. They also looked at it in terms of weeks. So more than 14 drinks a week in the male or more than 7 drinks in the week for a female. But here's the part that I found very interesting. They defined an older adult as over 40 years. Most of us wouldn't think of someone being over 40 years as being older, but that is the age that they looked at. The mean age of their sample was actually 39 with a range of 21 to 69 years. Now, although they did find greater cognitive deficits in heavy users of alcohol that were older than in those that were younger heavy drinkers, they also did find that there was no age difference when they looked at light or moderate or abstinent individuals. So I can hear you saying, so what? What does this matter? Who cares? Well, I think it does matter because although the sample size was quite small, it looks at the potential effect of heavy alcohol use to premature cognitive aging. So I think that's where the implication of this may be. But again, small study size, but I just love the way they defined an older heavy drinker as being over the age of 40. Other toxic substances that can affect mental status include heavy metals. We've talked a lot about lead poisoning and how it can lead to difficulty with iron deficiency anemia, but we also have to think about what it does to the brain, because that's one of its primary negative effects. Insect venom, sedatives and hypnotics, those are all important. We also know that metabolic derangements can cause altered mental status. We're going to talk a little bit about the effect of sodium. We've previously talked about glucose, and then of course oxygen makes a whole lot of sense. If someone is hypoxemic or hypoxic, that lack of oxygen can lead to a altered mental status. And the last piece on the pathologies is the ability and our clarity in differentiating between dementia and delirium, because they are not the same thing. Dementia is a chronic onset and is characterized by a slow decline in our cognitive function, but our awareness is not impaired. So you've got slow cognitive decline, no impairment of awareness, chronic. Delirium, however, is acute, and it has a fluctuating cognitive impairment, and it has varying degrees of awareness. So dementia and delirium are quite different. Now, as promised, we'll take a closer look at sodium imbalance and the effect of sodium on the central nervous system. Both hyper and hyponatremia have negative cognitive effects. So when we look at hypernatremia, generally the hypernatremia is either due to a loss of water or an acute increase in sodium intake. So if you're thinking about the loss of water, you're thinking about the sodium being very concentrated, or that acute rise of intake of sodium where there is not a concomitant increase in the amount of water that's taken in. As a result, then, with the hypernatremia, you have both an intracellular as well as an extracellular dehydration, which then leads to an increase in the osmolarity. Some of the pathologies that can actually lead to this include diabetes insipidus, which is insufficient antidiuretic hormone, so not enough antidiuretic hormone, elevated levels of aldosterone, Cushing disorder, are the three things to watch for. There are also less specific disease states, but things that lead to hypernatremia. So anything that causes diarrhea can lead to the loss of water and therefore hypernatremia. And insufficient water intake obviously would cause a concentration of the sodium level. And this insufficient water intake could be an inability to access water, like someone is confused or demented, or they are restrained in a hospital system, and so they can't reach the water pitcher or can't get to a water source. This also happens at all ages when we use hyperosmolar tube feedings. Hyperosmolar tube feedings are generally any tube feeding formula that is greater than 1 calorie per cc. Well, if we don't give them free water or additional water in addition to their tube feeding, they are more likely to develop a hypernatremia. The last source of hypernatremia can be iatrogenic. Usually, you're more likely to see this in an intensive care unit when we are treating a cerebral edema. Because what happens here is we infuse hypertonic saline. With that infusion of hypertonic saline, remember that leads to the sodium moving outside of the cell because you're dehydrating the cells. With the hypernatremia, CNS manifestations are the most serious. The individual will present with hyperreflexia. They may be confused, that confusion may lead to a loss of consciousness and a loss of total awareness. They may progress to coma. The individual may present with seizures, And they may also demonstrate cerebral hemorrhage as well because of this dehydration. And again, these CNS manifestations are related to dehydration of those brain cells. Let's look at the other side of sodium balance, which would be hyponatremia. With hyponatremia, there's a loss of sodium or a decreased intake of sodium, or most commonly, volume overload, a dilutional effect. Hyponatremia is the most common electrolyte disorder in hospitalized patients. Both hyper and hyponatremia are extremely important in elders because they both occur in elders, and you'll see a lot of negative effects from the sodium balance in an elder. As a result of the loss of sodium, the decreased intake of sodium, or volume overload, this creates a hypoosmolar state. As a result, the water moves into the cells, causing those cells to swell. With the loss of sodium, or the dilutional effect causing a perceived loss of sodium, the cells lose the ability to both depolarize and repolarize. Remember the movement of sodium and potassium across the cell membrane. Disease states that you might see this in include SIADH, or syndrome of inappropriate antidiuretic hormone secretion. This you'll see in a lot of this syndrome is seen in a lot of associated with a lot of other pathologies, and can be anything from metastatic cancer to some pulmonary diseases, the postoperative phase, to head trauma. You'll see it in a variety of instances. You may also see this in some kidney tubule disorders where the tubules lose the ability to reabsorb sodium. More commonly, however, we'll see this as a part of our diuretic therapy because many of our diuretics block the reabsorption of sodium. You'll see this in individuals with extensive burns, or anyone who has a very high water intake without an associated sodium intake. That again goes to that dilutional effect. Severe hyponatremia is deadly to the central nervous system. This may start as lethargy. They may complain of a diffuse headache, become confused, and their level of consciousness begins to drop. They experience coma, seizure, and cerebral edema. The cerebral edema is what gets us in trouble because remember that water moves into those cerebral cells, and the cerebral edema is absolutely deadly to the brain. So from the electrolyte disorder, let's look at some neurodegenerative diseases. And the two neurodegenerative diseases we're going to take a look at are Alzheimer's type dementia and Parkinson's disease. There are a number of different types of Alzheimer's type of dementia, and that's why we're starting to call this Alzheimer's type as opposed to trying to call everything Alzheimer's disease, because not all dementia is Alzheimer's. We know that, but we also know that there are some common characteristics, so that's why we can call it Alzheimer's type dementia, because of the common characteristics with the traditional Alzheimer's disease. One of the forms of Alzheimer's type dementia is due to a genetic defect, and this is thought to be due to an autosomal dominant link. And this occurs, more likely with an early onset Alzheimer's type dementia. Do we have a single gene? Not so far, but we are increasingly finding that an early onset dementia, which is an Alzheimer's type dementia that manifests prior to the 60s, is more likely due to the autosomal dominant link. We also know that Alzheimer's type dementias are strongly associated with a number of environmental factors. So the suspected environmental factors of dementia were identified and kind of pulled together very nicely by a meta-analysis that was done by Bilo et al. In 2016. And what they actually did is in the meta-analysis, they looked at linkages between environmental factors and dementia. So some of those environmental factors that they looked at or that they identified included depression, low social contacts, and the high incidence of benzodiazepine use. The other things they looked at is other risk factors, and these included, as I identified, depression, but also type 2 diabetes and a decrease in physical activity. Now, one of the questions that was raised in the meta-analysis, I think very appropriately so, was whether or not was the depression a risk for dementia, or was it part of the prodrome as people began to experience dementia? So was did the depression come first, or was it developing as a result of the dementia? So that was a good question, I thought. The more typical type of Alzheimer's type dementia has a late onset, and late onset dementia is usually dementia that occurs in the 60s, in our 60s and 70s. Now, we know that there are numerous etiologies that have been proposed. One of the most popular etiologies has to do with amyloid. And specifically, this is brain amyloid beta. Brain amyloid beta is present in 50 to 60% of brains of cognitively healthy individuals over the age of 60. However, we have identified that there are a fairly large number of deposits in Alzheimer's brains. We've started, however, to use this amyloid, this brain amyloid beta, as a surrogate marker for Alzheimer's disease. We know that there is a potential etiology of atherosclerosis. This is the vascular dementia. This vascular dementia, due to the atherosclerotic process, is thought to be a major player in those individuals with type 2 diabetes who experience dementia, as well as individuals who are hypertensive and experience dementia. We've also looked at inflammatory etiologies, oxidative stress etiologies, and the list goes on. When we look at Alzheimer's type dementia, however, especially when we look at the amyloid deposit as the etiology, we see neuritic plaque formation. And these neuritic plaque formations lead to insoluble filaments within the brain. These insoluble filaments, which means the body doesn't know how to break them down or doesn't have the ability to break them down effectively, causes disruption in the neuron impulse transmission. As those neuron impulses continue to have a disrupted transmission, they then begin to die. As we lose the neurons and the synapses in the cerebral cortex and in the subcortex, this has the characteristic negative and damaging effect on memory function. The end result of this Alzheimer's type dementia, with the loss of the neurons, the loss of our synapses, and changes in both the cerebral cortex and the subcortex, is brain atrophy. This brain atrophy is characterized by a decrease not only in the weight of the brain, but also the volume of the brain. At the same time, there is a loss of the neurotransmitters. This is a chronic, slowly progressive dementia and disorder. Now, this is a bit different. Remember that autosomal dominant link we were thinking about, the early onset? That tends to be a more rapid progression. Before we move on to Parkinson's disease, it's also important that we differentiate between Alzheimer's type dementia and forgetfulness. When we think about, so we've talked about dementia and we now understand what that is. So when we think about forgetfulness, and people say, oh, of course I'm forgetful, I'm getting older. Well, no, not necessarily. However, when we think about forgetfulness, there are two sort of major categories. One is age-associated memory impairment, and the other is age-associated cognitive decline. And these two things are different, but they both get kind of classed under forgetfulness sometimes. With age-associated memory impairment, this affects episodic memory, and it affects primarily elders. So you don't usually see this younger, and it's the episodic loss, some memory impairment. So there are some things that we have, a few things that we forget. Age-associated cognitive decline is more extensive than the episodic memory loss or the episodic memory changes. What's very important about the age-associated cognitive decline, remember it's more extensive than the episodic, is this may actually progress and has a tendency to progress to the Alzheimer's type dementia. And so as a result, then, we want to follow this much more carefully. When we look at how to diagnose this cognitive decline, the first thing we do is rule out everything else that could be causing it. We want to know, is this sudden or is this gradual? If it's sudden, we look for a more sudden pathology. So is this due to medications? Is this a frequent hypoglycemia? Has it been somewhat gradual? Could this be hypothyroidism? Could this be depression? Is this someone who has experienced frequent concussion? And what we're actually looking at is the beginning stages of chronic traumatic encephalopathy. Does this individual, is this the beginning of multi-infarct dementia? That frequent, some people would call these mini strokes, but they really aren't. We know that that's not an appropriate term, but are there small infarcted areas within the brain that are leading to this dementia? Sorry, I don't know why that keeps happening. Now, let's characterize Alzheimer's type dementia with Parkinson's disease. Parkinson's disease is also a neurodegenerative disease, but very, very different. Parkinson's disease is a degeneration of the basal ganglia. As the basal ganglia degenerate, this is due to a decrease in the dopamine-generating cells in the substantia nigra in the midbrain. Parkinson's disease is characterized by the presence of a characteristic cell called the Lewy bodies. Now we know that dopamine is an excitatory neurotransmitter, and that dopamine is important because it acts as a messenger between that substantia nigra and the corpus striatum. As a result, then, it's part of our extrapyramidal system to coordinate our motor movement. Without that dopamine, we have ineffective communication. Therefore, this manifests as a loss of movement coordination. The way this manifests, then, is a resting tremor, rigidity, bradykinesia or slow movement, and postural instability. Now, if you look at someone who demonstrates Parkinson's disorder, the resting tremor is very, very common. But when they reach for something, they're able to reach for it appropriately. So they don't have it. So it's a resting tremor, not an intention tremor. The rigidity and the postural instability frequently manifests as a lack of emotional changes in the face during the experience of emotions. And with the postural instability, individuals try with Parkinson's sort of compensate for that with a shuffling gait and a shuffling walk. Also associated with Parkinson's disease is degeneration of the locus coeruleus. The locus coeruleus is in your pons. Because of the degeneration of the locus coeruleus, there's a lack of norepinephrine. Remember, norepinephrine regulates arousal as well as our autonomic activity and is an excitatory neurotransmitter. Because of the lack of norepinephrine, there is a worsening of the behavioral symptoms, which includes both cognitive slowing as well as a depressed affect and depression. The last set of disorders we want to talk about, or something for lack of a better phrase, I'm going to talk about neuropathopotpourri. My expectations in this area is that you understand what it is and where it occurs in the brain, and then the characteristics of the pathology. So there are 4 pathologies that we're going to talk about. ALS, or amyotrophic lateral sclerosis, myasthenia gravis, and these are motor neuron diseases. Then we'll look at multiple sclerosis and Guillain-Barré, which are myelin sheath disorders. So ALS is the degeneration of the upper and lower motor neurons. So we're talking about issues within the motor cortex, the brain, and the spinal cord. So our concern is with those cells that control voluntary movement. In ALS, because it's the degeneration of the upper and lower motor neurons, there is no sensory or cognitive impairment. And so that's important that we want to remember that. There is thought in a very small percentage, about 5 to 10% of individuals with ALS, that this has a genetic component. For those with a genetic form of ALS, this is a mutation on chromosome 21 of superoxide dismutase. This is an autosomal dominant disorder that causes rapid degeneration of the upper and lower motor neurons. Because of the degeneration of the neurons, there are fewer neurons. The axons begin to degenerate. As a result, with that degeneration, there is a demyelinization and a sclerotic process that then occurs, therefore lateral sclerosis. The muscles begin to decrease in size. At the same time, there is the identification of some inclusion bodies, and this is called ubiquitin. And these inclusion bodies, the ubiquitin, are associated defects in protein degradation. Again, going back to that idea of the muscles decreasing in size. Myasthenia gravis, which is also a disease of the neuromuscular junction, is due to an autoimmune disease, and the autoimmune disease affects acetylcholine. Most of the acetylcholine, because it's neuromuscular, we're concerned with the receptor area. So what happens with this autoimmune disease, and we can measure the autoimmune, we can measure the autoimmune antibodies. One of 2 things can happen. The antibodies may block the enzymes that actually break down the acetylcholine. So that's what the autoimmune process does. It blocks the enzymes. The autoimmune antibody formation may also destroy the receptors so that there are fewer acetylcholine receptors. As a result, then, the tyrosine kinase cannot work. The symptoms of myasthenia gravis, because it's at the neuromuscular junction and you're unable to break down acetylcholine, means that you tend to have progressive symptoms, and these symptoms target or manifest in small active muscles, and the function of these small active muscles tend to worsen through the day because you've run out of acetylcholine. So these small active muscles where you'll see this occur initially are in the palpebral muscles, which are your eyelids, but also the muscles that affect chewing, speech, these very small repetitive muscles. And again, it's all about the ability to use the acetylcholine. It's a disease of the neuromuscular junction, either blocking the enzyme that breaks down the acetylcholine or blocking the function of tyrosine kinase, which is that enzyme, or the receptors aren't responsive. Now, getting away from the neuromuscular junction itself, multiple sclerosis. I'm starting to think I have multiple myasthenia gravis because my speech is off, but I don't. Multiple sclerosis is a disease of the myelin sheath. We don't know exactly what causes multiple sclerosis, although we think that there is a possible autoimmune connection. What happens with multiple sclerosis is the myelin sheath itself is actually destroyed. And because that myelin sheath has been destroyed, nerve transmission is interrupted. The classic presentation, or the classic thing we look for in multiple sclerosis, are some unusual presence of unusual substances called oligoclonal bands. We also see an increase in the levels of IgG. Yeah, once again, we've got this immune system component that we're very, very interested in with this. Now, because the other thing that happens with multiple sclerosis, which tends to make us think this has an autoimmune component, is this is a disease that is characterized by periods of remission and exacerbation. The most common manifestation of this that you'll see, there's people manifest with unremitting fatigue. They may have difficulty with ambulation. They may have some muscle spasticity. And very interesting, about 30% of individuals present with an optic neuritis. Once again, you're getting that idea that there may be something related to that autoimmune function, the immune system. Guillain-Barré is the last disorder we'll talk about in potpourri, and once again, Guillain-Barré is a disease of the myelin sheath. In Guillain-Barré, antibodies are produced that attack the Schwann cells. The Schwann cells are the cells in our spinal cord that maintain the myelin sheath. In virtually all cases, this Guillain-Barré syndrome is preceded by a flu-like viral syndrome. The most common in this, although the prodrome is a flu-like viral syndrome, it has also been strongly associated with a fairly common bacterium. And this bacteria is Campylobacter jejunum. Campylobacter jejuni is the #1 gram-negative rod bacteria that is associated with the development of Guillain-Barré syndrome. Generally happens 2 to 4 weeks after someone has had a Campylobacter infection, with the maximum deficit occurring within 12 days, maybe up to 4 weeks. But what's very interesting about Campylobacter, or the Campylobacter jejuni, is that this bacteria has antigens in a capsule. And the antigens in this capsule, the bacteria's capsule, that when the immune system responds to the bacteria, the antibodies that are produced by the immune system actually cross-react with the glycolipids in the myelin sheath itself. So as a result, those antibodies, with the cross-reaction with the glycolipids throughout that myelin sheath, are actually causing the damage. Guillain-Barré syndrome is characterized by an ascending paralysis, so it begins in the lower extremities and ascends up, and it can involve the respiratory system. And then as healing occurs, the recovery follows a descending pattern. Most individuals with Guillain-Barré recover completely from the Guillain-Barré syndrome. So we've talked a lot about different kinds of things here. We started by talking about altered mental status and a whole host of things that can cause an altered mental status. We talked about Alzheimer's type dementia, and we differentiated between Alzheimer's dementia and age-associated memory impairment and age-associated cognitive decline. The second neurodegenerative disease we talked about was Parkinson's disease, which is characterized by changes in the substantia nigra. Did I say that wrong? Hold on, give me a sec. Nope, got it right. Substantia nigra. Sorry, I doubted myself there for a minute. And then we moved on to some disorders and diseases of the neuromuscular junction as well as the myelin sheath itself. I apologize for that lapse I just demonstrated. I hope this information has been helpful, and you can differentiate among the things that we've talked about. Please let me know if you have questions or if I inadvertently confused you about absolutely anything. Thank you so much for your attention.